We start with, what is serotonin syndrome? Most people know serotonin as the feel-good chemical, but here's the thing, you can absolutely have too much of it. When serotonin levels in the nervous system go beyond what the body can handle, you get serotonin syndrome. And this isn't some rare, unpredictable mystery reaction. It is entirely foreseeable. It happens when drugs, usually more than one, push serotonin activity over the danger threshold, and it can move from mildly uncomfortable to life-threatening in the space of hours. This module is going to walk you through exactly what it is, why it happens, how to recognize it, and most importantly, how to manage it. What does serotonin actually do in normal life? It regulates mood, sleep, appetite, gut function, and pain. It's essential. The problem isn't serotonin itself, it's too much of it, stimulating two specific receptors beyond their normal range. The first is the 5-HT1A receptor, found mainly in the brainstem and spinal cord. When this gets overstimulated, the motor neurons in the spinal cord become hyperexcitable, and that produces Clonus and exaggerated reflexes. The second is the 5-HT2A receptor, found more in the cortex and autonomic nervous system. Overstimulate this and you get agitation, confusion, and the autonomic features, the racing heart, the sweating, the dangerously high temperature. So the two receptors explain the two main parts of the clinical picture. Understanding this makes the whole syndrome make sense. Two receptors, one in the spinal cord driving the movement abnormalities, one in the brain driving the mental state and autonomic chaos. That's the whole mechanism in a sentence. So what does serotonin syndrome actually look like when you walk into the room? Picture this, a patient who has just had a medication change or started a new drug. They're agitated, not drowsy but genuinely restless and anxious. They're sweating through their gown, their heart rate is fast, and when you test their reflexes they're brisk, maybe very brisk, and if you try to dorsiflex their foot and hold it, it beats rhythmically back against your hand. That rhythmic beating is called Clonus. And Clonus in someone on serotonergic drugs is the single most specific sign pointing to serotonin syndrome. The three domains together, neuromuscular, autonomic, mental state, form the classic triad. You don't need all 12 possible symptoms, you need the pattern. The triad is your diagnostic anchor, but Clonus is the key. That rhythmic beating of the foot against your hand when you hold it dorsiflexed. Learn to look for it. It's the sign that tells you what you're dealing with. What actually causes serotonin syndrome? The simple answer is too many drugs pushing serotonin activity up at the same time. But let's understand the 5 mechanisms, because this is what makes certain drug combinations so dangerous. Imagine serotonin as water in a bathtub. First, you can turn the tap on harder by giving more building blocks to make serotonin. Second, you can block the plug hole by stopping the enzyme that breaks serotonin down. That's what MAOIs do. Third, you can squeeze the bath sponge hard and release a surge of serotonin all at once. That's what amphetamines and MDMA do. Fourth, you can block the drain, stopping serotonin from being recycled back into the nerve ending. That's how SSRIs work. And fifth, you can directly press the receptors and activate them, even without changing the serotonin level. When you combine two drugs using different mechanisms, you get additive effects that can tip serotonin activity into dangerous territory. The bathtub analogy makes this stick. MAOIs block the drain, SSRIs block the overflow. Add both and the tub overflows, that's serotonin syndrome. Combine any two mechanisms and you multiply the risk. Which drug combinations are the most dangerous? The answer is anything involving an MAOI. MAOIs block the enzyme that destroys serotonin. So when you add any drug that increases serotonin on top of that, there is nowhere for the serotonin to go. It accumulates to toxic levels. The MAOI and SSRI combination is one of the most dangerous in all of pharmacology. There have been deaths. The washout rule exists for exactly this reason. 2 weeks after stopping an MAOI before starting an SSRI, and 2 weeks after stopping an SSRI before starting an MAOI. Fluoxetine is the exception that catches people out. Because its active metabolite stays in the body for weeks, you need 5 weeks of washout before starting an MAOI after fluoxetine. Now here's one that surprises clinicians, tramadol. Most people think of it as a simple painkiller, but tramadol has 3 serotonergic properties. It's a weak opioid, it blocks serotonin reuptake, and it has weak MAOI-like properties. Combine that with an SSRI and you have a real risk. And linezolid, an antibiotic given for resistant infections, is also a reversible MAOI. Patients on SSRIs who need linezolid are at risk, and this gets missed in hospital settings because nobody thinks of an antibiotic as an MAOI. MAOI combinations are the red line. Never cross it without a proper washout. Tramadol is the surprise, it's not just a painkiller, and linezolid is the hidden trap in the hospital setting. These are the three that will catch you out if you're not watching. Who is at risk? Let me give you the full picture. SSRIs are the most commonly prescribed serotonergic drugs, and they're in a huge proportion of the population. Then SNRIs, TCAs, particularly clomipramine, MAOIs, and remember that includes linezolid, the antibiotic. In the opioid category, tramadol carries the highest risk because of its triple mechanism. Triptans, used for migraines, are serotonin receptor agonists and can contribute. And then the drugs people often don't consider. Lithium enhances serotonin transmission. St. John's wort, an over-the-counter herbal remedy, blocks serotonin reuptake. Dextromethorphan is in many cough medicines and has serotonergic properties. MDMA causes massive serotonin release. And cocaine blocks serotonin reuptake. The point is that the list is much longer than most clinicians realize. And many of these drugs are things patients are taking without telling the doctor. Herbal remedies, cough medicines, recreational drugs. A thorough drug history, including OTC and herbal, is essential in any patient presenting with this clinical picture. The full list is longer than anyone expects. St. John's wort from the health food shop and cough medicine from the chemist can both contribute to serotonin syndrome. The drug history has to include everything prescribed, over-the-counter, herbal, and recreational. What is the most important physical sign to look for in serotonin syndrome? Clonus. Let me make that really concrete. You hold the patient's foot and you briskly push it upward, dorsiflex it, and you hold it there. In a normal person, nothing happens. In serotonin syndrome, the foot beats rhythmically back against your hand. Thud, thud, thud. That rhythmic beating is clonus, and it's the single most specific sign of serotonin excess. More than 3 beats is abnormal. You can also see it in the eyes, ocular clonus, where the eyes make rhythmic horizontal oscillating movements. It looks like a fine nystagmus, but it's rhythmic and horizontal. Alongside clonus you'll find hyperreflexia. The reflexes are overactive. Tap the knee and the lower leg swings up much more forcefully than expected. You might also see a visible tremor. And in severe cases the muscles become truly rigid, stiff, heavy, inflexible, particularly in the lower limbs. If that rigidity becomes severe enough, the patient may not be able to breathe properly. Test for clonus. That's the clinical action from this slide. Dorsiflex the foot, hold it, count the beats. More than 3 beats in a patient on serotonergic drugs, you have your answer. This single test is more specific than any blood result for this diagnosis. Now we come to the features that make serotonin syndrome dangerous. The autonomic features. Your autonomic nervous system controls the things that happen without you thinking about them. Heart rate, blood pressure, temperature, pupil size, gut activity. In serotonin syndrome, all of these go haywire. The heart rate climbs. Tachycardia, often above 100 to 120 beats per minute. Blood pressure rises. The patient sweats profusely, drenching sweats, not just a light perspiration. The pupils dilate, and the gut goes into overdrive. Hyperactive bowel sounds and diarrhea because the gut wall is densely packed with serotonin receptors. But the most dangerous of all is the temperature. As serotonin syndrome escalates, the continuous muscle activity generates enormous amounts of heat. The temperature rises, and above 41 degrees Celsius, you are in a medical emergency. At that temperature, muscle proteins start to break down, rhabdomyolysis, the kidneys can fail, the blood clotting system can collapse, and without treatment the patient can die. The temperature is the danger signal. Watch it closely. If it's rising, the patient is deteriorating. Above 41 degrees, you're in emergency territory, and paracetamol won't help. This fever is made by muscle activity, not by the hypothalamus. You have to cool the patient physically. When you walk into the room of a patient with serotonin syndrome, what will you see first? Agitation. The patient is not drowsy and calm. They are distressed, restless, and unable to stay still. They are anxious. They may be confused and unable to follow what you're saying. They startle easily. Loud noises or sudden movements produce an exaggerated response. This is a really important point clinically because agitation in a hospital patient can easily be misinterpreted as a psychiatric episode. And what happens then? Someone reaches for an antipsychotic to calm them down. In serotonin syndrome, that is a dangerous mistake. It adds dopamine blockade to serotonin excess and risks triggering neuroleptic malignant syndrome on top of what's already happening. The lesson here is always think about what drugs the patient is on before reaching for something to manage agitation. In severe cases, the mental state deteriorates further into delirium and eventually coma. The mental state trajectory tells you how sick the patient is getting. Agitation is the clinical picture, not sedation. If someone sends you to sedate a confused patient and they're on serotonergic drugs, stop and think. Check for Clonus. Check the temperature. Don't reach for haloperidol before ruling out serotonin syndrome. Not all serotonin syndrome looks the same. It exists on a spectrum from mildly uncomfortable to life-threatening, and understanding the 3 levels helps you make the right management decision fast. Mild. The patient has some tremor, their reflexes are brisker than normal, their heart rate is up, they're sweating, and they're anxious. They are uncomfortable but you can talk to them. This is not immediately life-threatening but it needs treatment and very close observation, because mild can become moderate quickly. Moderate. Now you have a temperature that's climbing, maybe touching 39 or 40 degrees. Clonus is present and easily inducible. The agitation is more marked. The patient needs active management now. Severe, temperature above 41 degrees, marked muscle rigidity, and the blood tests start showing rhabdomyolysis. The muscles are breaking down, metabolic acidosis, possibly seizures. This patient is critically ill. ICU, aggressive cooling and potentially intubation. The key message is that severity can escalate. A patient who looked mild 2 hours ago can be severe now. Continuous monitoring is not optional. The temperature tells you where the patient is on the severity spectrum and which direction they're heading. Mild stays under 38, moderate approaches 40, severe exceeds 41, and above 41 you are running out of time. How do you actually diagnose serotonin syndrome? Not with a blood test, not with a scan. You diagnose it at the bedside. The tool we use is the Hunter criteria, developed in 2003 and validated on nearly 500 patients. It has a sensitivity of 84% and a specificity of 97%, meaning it's highly accurate. Here's how it works. You need 2 things. First, a serotonergic drug in the past 5 weeks. That 5-week window accounts for drugs like fluoxetine whose active metabolite stays in the body for weeks after stopping. Second, one of 5 specific clinical patterns. And here's the beautiful thing about the Hunter criteria, all 5 patterns are built around Clonus. It makes Clonus the diagnostic cornerstone. Pattern A is the simplest, spontaneous. Clonus alone is enough. The foot or eyes are beating rhythmically without you even triggering it. Diagnosis confirmed. Patterns B through E combine Clonus with other features, agitation, diaphoresis, hyperreflexia, or hypothermia. You work through the patterns and if any of them fit, you have serotonin syndrome. Drug exposure plus Clonus. That is the diagnostic core. If the patient has been on a serotonergic drug in the past 5 weeks and they have Clonus, you have serotonin syndrome. The Hunter criteria just formalizes what Clonus means in this context. Here's the differential that trips people up, and getting it wrong is genuinely dangerous because the treatments pull in opposite directions. Serotonin syndrome and neuroleptic malignant syndrome can both present with hypothermia, autonomic instability, and altered mental state. So how do you tell them apart? Ask yourself 3 questions. First, what drugs is the patient on? Serotonergic drugs point to SS. Antipsychotics or antiemetics that block dopamine point to NMS. Second, how fast did this come on? SS develops within hours. NMS develops over days to weeks. Third, what is the neuromuscular picture? And this is the clinical exam that decides it. In serotonin syndrome, the reflexes are exaggerated and you get Clonus. In NMS, you get lead pipe rigidity. The muscles are uniformly severely stiff and no Clonus, no Clonus. That single finding separates the 2 conditions at the bedside. The bowel sounds are also useful. Hyperactive in SS, reduced or absent in NMS, and the treatment cyproheptadine and benzodiazepines for SS, bromocriptine and dantrolene for NMS. Give the wrong treatment and you make the other condition worse. Is there Clonus? Yes. Serotonin syndrome. No, think NMS. That one physical examination finding decides the diagnosis and therefore the treatment. It genuinely cannot be overstated how important it is to examine for Clonus in every patient presenting with hypothermia and confusion. What is the single most important thing to do when you suspect serotonin syndrome? Stop the drugs. Not reduce the dose, stop them, all of them, every serotonergic agent the patient is taking. This removes the source of the problem, and in mild to moderate cases, stopping the offending drugs alone is often enough to reverse the syndrome within 24 hours. While you're stopping the drugs, start monitoring temperature continuously, not just a one-off check, heart rate and blood pressure, urine output, IV fluids because these patients are often dehydrated from sweating and diarrhea, cardiac monitoring because tachycardia and hypertension need watching. The instinct sometimes is to watch and wait, to see if the patient settles on their own. Don't act immediately. The condition can escalate quickly, and the earlier you intervene, the better the outcome. Stop, monitor, support. That's step one. And the word stop means all serotonergic drugs, not the last one added, not the one that seems most likely. All of them. The body needs the serotonin load to come down, and it can't do that while the drugs are still active. Once you've stopped the drugs and started monitoring, what do you give? Two drugs matter here. First, benzodiazepines. Diazepam or lorazepam. These are your primary pharmacological workhorse across all severities of serotonin syndrome. They reduce the muscle hyperactivity, the clonus, the myoclonus, the tremor. They control the agitation, and they reduce the risk of seizures. Crucially, they have no serotonergic effect whatsoever. You're not adding to the problem. Second, cyproheptadine. This is the specific antidote. Most people know cyproheptadine as an antihistamine. It's used for allergies, but it is also a potent 5-HT2A receptor antagonist, meaning it directly blocks the receptor that serotonin is overstimulating. The Maudsley Guidelines and the Oxford Handbook both recommend the same dosing. 12 mg as a loading dose, followed by 2 mg every 2 hours, up to a maximum of 32 mg per day. It only comes as tablets, so if the patient can't swallow, perhaps because of their level of consciousness, it goes down a nasogastric tube. Benzodiazepines first. They calm the muscle hyperactivity and agitation safely. Cyproheptadine second. 12 mg loading, 2 mg every 2 hours. Those numbers come straight from the Maudsley and Oxford Handbook. Know the dose, know the mechanism. What happens when the temperature keeps rising despite initial treatment? Temperature above 41 degrees Celsius is a medical emergency, and this patient needs ICU. Let me address the most common mistake first: reaching for paracetamol. Don't. It won't work. I know that sounds counterintuitive. You have a patient with a high temperature, and you reach for an antipyretic, but the fever in serotonin syndrome is not caused by the hypothalamus changing the body's temperature set point, which is how normal fever works and how antipyretics work. This fever is generated by the relentless muscle activity. The continuous clonus, myoclonus, and rigidity is generating enormous heat. To bring the temperature down, you have to stop the muscle activity. High-dose IV benzodiazepines reduce the muscle hyperactivity, which reduces the heat generation. Active cooling measures: ice packs to the armpits and groin, cooling blankets, cold intravenous fluids, physically remove the heat. And if the rigidity is so severe that the patient cannot breathe, you intubate and paralyze. Complete neuromuscular blockade stops the muscle activity entirely, and the temperature comes down. And a final warning: do not give antipsychotics for the agitation. I know it's tempting, but antipsychotics block dopamine, and in this clinical context that can trigger neuroleptic malignant syndrome on top of serotonin syndrome. Benzodiazepines manage the agitation. Antipsychotics make it worse. 3 rules for severe serotonin syndrome. 1. No paracetamol, it won't work and waste time. 2. Cool the patient physically: ice packs, blankets, cold fluids. 3. No antipsychotics, they risk NMS. Benzodiazepines and active cooling are your tools above 41 degrees. Let's end the management section with what not to do, because these errors are genuinely common and genuinely dangerous. First, no antipsychotics. I've said it before and I'll say it again. The reflex of giving haloperidol to an agitated patient is deeply ingrained in clinical practice. In serotonin syndrome, it's wrong. Use benzodiazepines instead. Second, no physical restraint. Holding a patient down might seem like the safe thing to do, but in a patient who is already generating dangerous amounts of heat from muscle activity, a physical struggle dramatically worsens both the hypothermia and the risk of rhabdomyolysis. If you need to control agitation, IV benzodiazepines. Third, no paracetamol for the temperature. It simply doesn't work here. Don't waste time on it. Fourth, don't ignore a mildly elevated temperature because it doesn't look alarming yet. A temperature of 38 degrees that was 37.5 an hour ago is more worrying than a static 38 degrees. It's the trajectory that matters. And fifth, do not continue the serotonergic drugs while you're waiting for test results to come back. Stop them now. The 3 never DOS: no antipsychotics, no physical restraint, no antipyretics, and the 3 DOS: benzodiazepines for agitation, cyproheptadine for the receptor, and continuous temperature monitoring to track the trajectory. Simple rules, life-saving consequences.